Hi everyone, and in this video I'll be discussing hematinics. So when we think of hematinics, they are nothing but they are the nutrients or the compounds which are required for forming blood components. For example, they are mainly required for hematopoiesis. And hematinics are usually given to treat nutritional anemia, that is iron deficiency anemia, as well as the megaloblastic anemia. So basically, when we talk of hematinics, they are nothing but nutrients or compounds which are used for formation of blood components, particularly hematopoiesis. Now, basically, there are two important hematinics. What we have, one is the iron, then the B12, and then folic acid. So these are the major hematinics. The minor ones are the copper and another one called pyridoxine. So these are the hematinics. So basically we are really discussing iron, B12 and folic acid, the pharmacology of them. First of all, let us take iron. So iron, you need to understand the preparations of iron, what we give as drug. What are the iron preparations we know of? So first of all, we can give the iron in the form of oral drug. The oral preparations are ferrous sulfate. Now this ferrous sulfate has 33% of elemental iron. It has 33% of elemental iron. That means if I give 100 milligram of this tablet, 100 milligram of this tablet, what is the content of iron? It is 33 milligram of elemental iron will be there. Suppose if I use a tablet of 200 milligram of this, then how much will be the elemental iron? It's around 65 to 66 milligram of elemental iron. That is the meaning of the 33% what I have written. So that is ferrous sulfate, very commonly used drug for managing iron deficiency. Now similarly we have ferrous fumarate. It also contains 33% of elemental iron. Then we have ferrous gluconate. Ferrous gluconate, it has only 12% of elemental iron. And then we have colloid ferric hydroxide. So ferric colloid hydroxide, it has 50% iron. And recently we have come up with a iron called carbonyl iron. It is called as highly purified iron preparation. It is an highly purified iron preparation. The advantage of carbonyl iron is less gastric irritation. So these are the oral supplementations. Either we give it in the form of tablet or in the form of syrup. Ferrous sulfate, fumarate, then ferrous gluconate, and we have colloid ferric hydroxide and carbonyl iron. Now coming to the pharmacokinetics, when we give iron orally, what is the pharmacokinetics I need to understand. Now when we give the iron orally, so this is the gut, this is the gut. In the stomach, there is an iron called ferric, Fe3 plus is ferric form. So ferric should be converted into Fe2 plus, and that is called the ferrous form. So the ferrous form is the one which gets absorbed. So ferrous form is the one which gets absorbed. And what environment will convert ferric to ferrous? So it should be acidic or basic. The environment should be acidic pH. So acidic pH will favor the iron to form ferrous, which is easily absorbed. And we know that iron absorption is maximum in the duodenum part. So what favors acidic pH is the administration of vitamin C. So they can ask in the exam, can we combine iron with vitamin C? Yes. This combination is rational because vitamin C makes the pH acidic and iron absorption is increased by making the iron ferrous. Another question they can ask you is, can we combine iron and PPI together and give to the patient? Together? No, because when I give PPI, that is pantoprazole, omeprazole, They make the environment alkaline and iron absorption is hampered. So these are two drug interactions which they can ask you in the exam. Now remember, when you are using iron should be administered in the empty stomach. So iron usually is given in empty stomach. So this is the pharmacokinetic aspect, and also don't give milk and iron. Milk and iron, they can also form complex, and that will also not allow the absorption of iron. Now where do you use oral iron? Obviously we use oral iron where? Number one, nutritional deficiency, that is iron deficiency anemia. So we use it in iron deficiency anemia, correct. Now one important application I want to tell you is, suppose the patient has hemoglobin of 9, that is lesser only 9, and you started a oral iron and the hemoglobin after 3 months became around 12. So should I stop the iron therapy when it becomes normal? So when the hemoglobin becomes normal, should I stop iron? Should I stop iron? So please pause the video and try to answer yes or no. So no. The reason why we should not stop the iron, even the hemoglobin has become normal, I will give the reason for this. Now, you take the example, this is the gut. This is the gut, and the iron that is in the form of ferrous is absorbed and it is stored in the intestine as ferritin. And it is also circulated in other parts of the body in the form of a protein called transferrin. So transferrin is the one which transport, and it will deliver the iron for two important things. One is for hematopoiesis, and one more, it is stored in reticuloendothelial system, that is the spleen and liver. These are the storage site. So it is stored in the form of ferritin. Now if the patient has hemoglobin of 9, and if I am giving iron and the hemoglobin becomes normal, the first thing what happens is the hemoglobin become normal because the iron is diverted in the synthesis of RBCs. But the stores are not replenished. So even when the hemoglobin has become normal, we have to continue the iron. Why do we want to continue the iron further? Is to replenish the stores of iron. So if you discontinue, the stores are not there and the patient will again become hemoglobin deficient. He will again suffer with iron deficiency anemia. That's why please remember this very important thing. If the hemoglobin becomes normal, patient comes with the report, sir, my hemoglobin is normal. What should I do? Don't tell the patient stop iron. Tell him to take for another 3 months. The reason is to replenish the stores. So even the hemoglobin comes down, the stores will give the iron, so the hematopoiesis continues further. Very, very important point. So I told you iron is used for iron deficiency anemia. Second, it is used whenever the demand is excess. So which patients the iron requirement is more? Obviously in a pregnant woman, in a child, and in lactation. The iron demand is more because the hematopoiesis is more in them. Next, whenever the patient has chronic blood loss. Now, what is the reason for chronic blood loss? For example, if the patient has some bleeding area in the form of fistula, fissures, if there is ulcers in the stomach, or the lady has menorrhagia. So in India, they will have menorrhagia and they will be losing the blood. Then hookworm infestation. So you have to treat the cause. You have to treat the cause. Without treating the cause, only if you give iron, it will not going to help. So treat these causes. Now you take the example. Suppose there is a pot and the pot is empty. So for that you are putting the water through the tap. So this is the tap. Through the tap you are giving the water inside. So it's like giving iron. Now it will fill. But if the tap has, if the pot has a hole, whatever you give, it will be lost and the tap will keep on giving, but the pot will not fill. Same thing happens here. If the patient has ulcer or fissure or anything what I have mentioned here, if you start giving iron, you will not correct the hemoglobin because there will be always a loss. So correct that, patch up this loss, that is treat the cause. So this is very very important. So once we understood the application of iron therapy, that is oral, what is the adverse effect when we give this iron orally? Obviously, patient will complain of gastritis, a most common problem. Second, it can cause teeth discoloration. Teeth discoloration. The reason why the teeth will get discolored because when they drink iron syrup, the iron syrup can stain their teeth. So you should tell the patient about that. And patient will have both diarrhea as well as constipation. They may complain both, but what is the most common problem is diarrhea is the most common compared to constipation, and the stool will also change the color. So black coloring of stool or black stools. So you should tell the patient already that when you give iron, the stool will become black. Otherwise, patient will get worried. So the adverse effect are gastritis, teeth discoloration, diarrhea is most common compared to constipation, and the blackening of stools. So this is one way of giving iron. The other way is we can give iron in the form of parenteral iron therapy, not oral, parenteral iron therapy. The basic question is why should I give a iron parenterally? Many a times patient may not be able to take oral because of the adverse effect. So patient is intolerant to oral iron therapy. Intolerant to oral iron therapy. So why the patient may be intolerant? He may have gastritis when he takes that and stops the medication. So in that time we have to give injection. Second, patient has malabsorption. So even though he is taking oral iron, it may not be absorbed properly. Third, if the patient has severe iron deficiency anemia, so then we cannot wait the oral drug to work faster. Then you have to give parenteral. Suppose the patient has chronic kidney disease, you know that in chronic kidney disease, the erythropoietin level decreases. So patient will have anemia due to chronic kidney disease. In that case, what we do is, along with erythropoietin, we add iron injections. So why should we use iron? Because when you are correcting anemia, you will give erythropoietin, correct, it will increase the reticulocyte synthesis. But along with that, iron should also be supplemented so that erythropoiesis occurs in a proper manner. So this is what we need to do. When you are correcting anemia in CKD patient, along with erythropoietin, you have to give iron injection. Now, I told you the indications of parenteral iron therapy. You write it as indications of parenteral iron therapy. Okay. So what are the preparations then? What are the injections? What are available? Preparations. Yes. What are the name? Number one, a drug called iron dextran. The name is called iron dextran. So you can give it IV as well as IM, no problem. You can give it into the muscle or into the vein. Second, we have a drug called iron sorbitol citric acid complex. So it is called iron sorbitol citric acid complex. Remember, this is given IM only. Now, the question asked is, why not IV? It is not given IV. What is the reason for that? It is not given IV. What is the reason for that? Now, when we give this iron sorbitol citric acid complex, I will write it as ISC. Now, there is a protein called transferrin. This is the transferrin. Now, you know the role of transferrin. It is the one which transport the iron from one place to other. Now, this iron sorbitol citric acid, they will sit on the transferrin. So, when they sit on the transferrin, the iron will become free. So, free iron will be available. So, free form. So, iron will be in the free form and that will lead to iron toxicity. So, this will displace the iron from transferrin sites and the free form of the iron increases, leading to iron toxicity. So never give iron sorbitol citric acid complex in IV route. But dextran doesn't have that problem. Now remember, any iron preparation, what we give is there is a risk of allergic reaction. So the pharma companies are trying to come up with the iron preparation with less allergic phenomenon, and we came with two more drugs. They are called as ferrous sucrose, and one more is called ferric carboxy. It is called ferric carboxy maltose. Okay, so we have ferrous sucrose and ferric carboxy maltose. What is the advantage of them? The advantage is less allergy. They cause less allergy. Now, whenever you give a drug IM, iron injection IM, what is the point here? So, if this is the skin, below is the muscle, right? So, let me write like this. So, when I give an injection like this, what happens? I give iron injection here, it will form a track. So, when it form a track, the drug can come back from the track and come to the skin, and it can cause skin staining. So, whenever you are giving IM injection of iron, there is a chance of skin staining because you have created a track. When you give an injection directly into the skin, for example, this is the skin you gave it, and with that same track, the drug will come out. And it is colored, so it will stain the skin. Now, to avoid this staining, we use a technique called Z-track technique. We use a technique called Z-track technique. Now, they can ask you, why do we use it? To avoid skin staining. To avoid skin staining. So, what we do here is, this is the skin and this is the muscle. So, this is the muscle. So, when we give the injection, first what we'll do is we'll pull the skin, give the injection, then release the skin, and after releasing the skin, we'll remove the needle. So, when you do like that, that will create a Z track. I'll write like this. So, it will create a Z track inside the muscle. So, it will be like this. So, it will create a track like this, Z track. So, you can see here, I will highlight this. The track will be created like this. So, even the iron wants to come out, it will not come out to the skin, it will stay there only. So, this will not allow the skin to get stained, and that is the advantage of Z-track technique. That is only followed when you give it IM. Now, can you tell me some other drugs which are given by Z-track technique? Yes, they are antipsychotic drugs. Now, when we give antipsychotic drug IM, we follow this technique not to prevent staining, to make the drug longer acting. We don't want the drug to come out of the same track outside. We want the drug to stay inside the muscle. So, for antipsychotics also, when we give IM, we follow Z-track technique. Please mark that. So, that is about the Z-track technique. But there is a formula to calculate parental iron. Formula to calculate parental iron required. Parental iron required. What is the formula? So, formula is like this: 4.4 into body weight of the patient into hemoglobin deficit. That is the formula. What do you mean by hemoglobin deficit? For example, normal hemoglobin is 14 gram per deciliter and patient has 9 gram per deciliter. What is the deficit we have? It's around 5. So you have to substitute 5 here. That's it. That is the meaning of hemoglobin deficit. Another important thing you need to understand is in iron, it's a correlated topic with forensic, but still patient may end up with iron poisoning. Now, which patient can have iron poisoning? For example, a child. You would have kept iron capsule and a baby may swallow that capsule and come to the casualty. Now, whenever there is iron poisoning, the child will have nausea, vomiting, hematemesis. So, there is a chance of GI hemorrhage. So, this is typically seen. Now, whenever the iron poisoning comes, how do you manage? Yes, obviously we manage with managing the airway, breathing and circulation. Then do the gastric lavage. Why do we do gastric lavage? To remove the unabsorbed iron. Then, if there is iron inside the stomach, we want to decrease iron absorption. Now, how do I stop the iron absorption further so that the poison will not get inside? Number one, by using sodium bicarbonate. Now, why do we use sodium bicarbonate? You know that it is going to create alkaline environment and that will not allow iron to get absorbed. That is one strategy. And also by administering egg yolk. So egg yolk will form a complex with iron and that will also not allow this to get absorbed. There is no role of activated charcoal here, don't use it. Now, is there any antidote? Is there any antidote for acute iron poisoning? Very, very important. The name is called desferroxamine. So desferroxamine is a chelating agent. It is the drug of choice for acute iron poisoning. You can give it either IV or you can give it IM. So it can be given in both the routes. So very, very important, guys. Application of iron poisoning, the antidote, very, very important. Next, let me tell you one interesting concept here. They can ask you, where is iron absorbed maximally? Where is folic acid absorbed maximally? Or where is B12 absorbed maximally in the gut? So iron is maximally absorbed in the duodenum and folic acid is maximally absorbed in jejunum and B12 in the terminal part of ileum. And you know that B12 absorption in the ileum requires a factor called intrinsic factor. With the help of that only it is absorbed. So guys, until now what I discussed is about the iron deficiency anemia, the iron preparation, oral, parenteral, and the clinical applications, what you keep in mind, because iron deficiency anemia is a very common problem and they are going to ask in the exams. Moving on to another hematinic, it is called B12. Now, whenever there is B12 deficiency, what are the symptoms the patient will present with? Number one, the anemia. What is the anemia? It is the megaloblastic anemia. Second, the nerves also require B12. If it is deficient, patient will have neuropathy. Patient will have abnormal pain sensation or abnormal sensation, that is called paresthesia. So it can also cause subacute combined degeneration of spinal cord, and other complaints are glossitis and knuckle pigmentation. So these are seen in B12 deficiency. Now remember, the B12 is very less in vegetarian diet, it's more in non-vegetarian diet. So most of the vegetarians will be B12 deficient and they require treatment with B12 supplementation. Now what are the preparations of B12? Let me tell you. The preparations are like this: cyanocobalamin. Then we have methyl cobalamin. Then we have hydroxycobalamin. So we have hydroxycobalamin. So these are the preparations of B12. Now coming to the uses, where do you use this? Where do you use it? Obviously, B12 is used in megaloblastic anemia. Now, when you are treating megaloblastic anemia, please remember one important point. We also use folic acid. Never use folic acid alone. Folic acid alone not used to correct this anemia. Why? Can you pause and tell me? Now let us imagine that patient has B12 deficiency. B12 is low. And we know that B12 is required for both the hematopoiesis and is required for nerves. So if a patient has megaloblastic anemia and I don't know whether it is because of folic acid or B12 deficiency. If I give only folic acid, what happens? The folic acid will divert the B12 towards the hematopoiesis. And whatever the low amount of B12 is diverted to that, the nerves will not have B12. So patient will have the nerve symptom, that is neuropathy and paresthesia. So the nerves will suffer. So that is the reason whenever you are correcting megaloblastic anemia, always supplement folic acid with B12. And don't worry, these are water soluble vitamins, nothing will happen. This is one of the reasoning question they can ask you in the exam. The second important anemia where we use B12 is pernicious anemia. Pernicious anemia. Now, what is pernicious anemia? Let me explain that. Pernicious anemia, there is a deficiency of intrinsic factor. Intrinsic factor deficiency. Now, the parietal cell in the stomach is going to synthesize the intrinsic factor. Now, I told you, intrinsic factor combines with B12. Particularly, let me draw. This is the ileum. So, what I am drawing is ileum. So, with the help of intrinsic factor, B12 will combine and then only the B12 gets absorbed. Now, if the patient has pernicious anemia, even if you give B12, it is not absorbed because there is no intrinsic factor. Then what to do for this? The B12 is not absorbed. That means for pernicious anemia, oral B12 will not work. It will not work. Then what to do? You have to give the B12 parenterally. So B12 is given parenterally, that is, it is given IM. And what we give is hydroxycobalamin. Now this is given. Now when we give like this B12 enters the circulation through the muscle. So from the muscle it will enter the blood vessel. And for this IM, it doesn't require intrinsic factor. So the question asked is, should we give this lifelong? Patient with pernicious anemia, should we give B12 lifelong? Yes, the patient requires lifelong therapy. So B12 has to be given IM every month lifelong. So can they take with diet? No, because even if they take with diet, B12 is not absorbed. So lifelong therapy is required for pernicious anemia, and we give IM B12 injection, not oral. Very, very important. Moving on to the other uses of B12. Another use is, it is also used in cyanide poisoning. So B12 is also used in cyanide poisoning. Now, what is the drug we use for cyanide poisoning in B12? It is hydroxycobalamin. So what do we use is hydroxycobalamin. Now, why do we use it? Now, in cyanide poisoning, this hydroxycobalamin combines with cyanide to form cyanocobalamin. And what is cyanocobalamin is B12. And what is B12? They are water soluble and they will go out in the urine. So urine eliminated. So the drug of choice for cyanide poisoning is hydroxycobalamin. So simple reason, cyanide will combine with hydroxycobalamin to form cyanocobalamin. It's nothing but B12 and that will go out in the urine. The other use of the drug is in case of diabetic neuropathic pains. I told you B12 are required for nerves and they are also used, B12 is also used in an amblyopia called tobacco amblyopia. So these are the uses of B12. Let me repeat. Number one, megaloblastic anemia, we use B12 plus folic acid. Never give folic acid alone. Then pernicious anemia, we require lifelong therapy. Hydroxycobalamin given parenterally, that is IM. Oral B12 will not work. Then we have cyanide poisoning. Hydroxycobalamin is a drug of choice. Then diabetic neuropathy and tobacco amblyopia. That is about B12. Moving on to another hematinic, they are called folic acid. Now, folic acid, the name is derived from folate because it is rich in green leaf vegetables. Now, what are the uses of folic acid? Number one, we use folic acid in nutritional deficiencies. So, patient is not able to take through the diet. Second, in the management of megaloblastic anemia. megaloblastic anemia, along with certain antiepileptics. Certain antiepileptics are known to produce folate deficiency. For example, along with antiepileptics, right, phenytoin. So phenytoin can cause decrease in folate level. There we use it. And folic acid is also used to decrease the risk of neural tube defect. Neural tube defect. So what is the dose of folic acid? That is commonly asked in the exam. Folic acid, if the pregnant woman has low risk and if she has high risk. If the pregnant woman has low risk or high risk. Low risk, you can give it at 400 microgram per day as prophylactic therapy. High risk, for example, she is already on anti-epileptic therapy, for example, valproate, carbamazepine. They can cause neural tube defect in the child. For them, you have to use higher dose, that is 4000 microgram per day. So this is the basic use of the folic acid, nutritional deficiency, megaloblastic anemia, along with antiepileptics, and to decrease the risk of neural tube defect. Now, similar to folic acid, we have one more acid that is called folinic acid. So folinic acid is also called as N5-formyl tetrahydrofolate. So it is also called as N5-formyl tetrahydrofolic acid. It has one more name that is called citrovorin factor. It is also called as leucovorin. So where to use it? What is the use of folinic acid? Number one, to manage methotrexate toxicity. It is used in management of methotrexate toxicity. Number two, it is used with a drug called 5-fluorouracil. It is used in cancers. So there is a regimen called FOLFOX. So FOLFOX consists of folinic acid. F stands for 5-fluorouracil, O for oxaliplatin. So 5-fluorouracil acts by inhibiting thymidine synthase, and that inhibition of thymidine synthase is enhanced by adding folinic acid. That's why folinic acid is used to increase the activity of 5-fluorouracil to inhibit thymidine synthesis. So the basic use is in methotrexate toxicity as well as in the management of cancer, particularly FOLFOX regimen. Which cancer is it used? A cancer called colorectal cancer. So that is about the folinic acid, a derivative of folic acid. But the disadvantage of folic acid is it is a bit costlier compared to folic acid. So most of the nutrition deficiencies we can give folic acid. Only in case of methotrexate toxicity and cancer we can use folic acid. Now moving on to the drug pyridoxine. So instead of calling the drug, I can call it as B12. Okay, take a cut of this. I will repeat again. So next, I am going to discuss pyridoxine. So pyridoxine is nothing but B6. Now, what is the application I need to understand about pyridoxine? Pyridoxine, it is used for certain conditions. Number one, INH overdose. If there is INH toxicity, pyridoxine is the antidote. Or if there is INH stands for isoniazid induced peripheral neuropathy. There also we use pyridoxine. So even when the patient is using INH, patient will develop an anemia called sideroblastic anemia. For correcting that also we use the drug pyridoxine. So pyridoxine basically is used in INH overdose, INH induced peripheral neuropathy, and also in sideroblastic anemia. Now there is a combination of doxylamine plus B6. Can you tell me where do we use this combination? We use it in morning sickness. And B6, you should remember a drug interaction for B6. What is the drug interaction? Levodopa and B6 should not be given together. The reason is levodopa is metabolized by an enzyme called peripheral decarboxylase. So levodopa is metabolized by peripheral decarboxylase into dopamine in the periphery. Now this enzyme activity is increased by B6. Now what happens when I increase the activity of peripheral decarboxylase? Most of the levodopa is converted to dopamine and less levodopa enters the brain and the drug efficacy decreases. So never combine levodopa with B6. This will decrease the efficacy of levodopa and patient will not have improvement of Parkinson's symptoms. Very, very important drug interaction. So that is about the drugs what are called as hematinics. And please remember all these are applied aspect what I taught to you. Iron, we discussed the iron deficiency anemia, the oral iron, and then the adverse effect, then parental iron indications, then what are the indications of parental iron, acute iron poisoning, what is the antidote, desferoxamine, then ZRAC technique to prevent staining when we give IM iron, then B12, what are the uses of B12, what are the preparations of B12, then folic acid and pyridoxine. So that is about hematinics. Thank you all.